Hello and welcome back. Today I'm going to discuss you about the actions of SGLT inhibitors on metabolism, renal function and blood pressure. So this is the second lecture on SGLT2 inhibitors. So I have used the text from this Diabetologia. You can also download a copy from this. I have used the matter in this text for the presentation of this topic. Myself, Santosh Abraham. I work as a specialist registrar in endocrinology and diabetes at Scarborough General Hospital. SGLT2 inhibitors, they reduce plasma glucose levels proportional to the glucose concentration and glomerular filtration of the glucose. SGLT2 inhibitors associated with a reduction in HbA1c by 7 to 10 millimole regardless of the background therapy. This is how the SGLT2 inhibitors impact on glucose reduction. They reduce fasting plasma glucose by 1 to 2 millimole per liter. So it is a greater reduction when compared with other glucose strategies. They also reduce postprandial glucose levels. The glucose lowering effect is dose dependent. In patients with less than 8% at least, when high dose therapy produced superior glucose lowering compared with low dose formulations. In those with poor glucose control, similar improvements were actually found. With both high and low dose. So the preferred strategy is to initiate patients on low dose with poor glucose control, because low dose will work even in patients with poor glucose control, whereas high dose is required when the HbA1c is better. The glucose lowering effect of SGLT2 inhibitors depends on the renal filtration of glucose also. So with a high EGFR, they filter more glucose than those with a lower EGFR. So the greater degree of glucosuria seen with SGLT inhibitors in those with poor glucose control further explains this, because a glucose mediated hyperfiltration and ambient hyperglycemia in these individuals contribute to increased glucose filtration. On the other hand, the glucose lowering effects of SGLT2 inhibitors are reduced in patients with EGFR less than 60 and almost absent with EGFR less than 30. Hence, SGLT2 inhibitors are not recommended when the EGFR is less than 30, not only because of the doubling of creatinine when you use them, but also because the efficacy is really reduced when the EGFR is less than 30. But the recent studies have pointed out that SGLT2 inhibitors could be effective even with EGFR as close to 20, but their effects may be primarily on decreasing the cardiovascular mortality more than the diabetes control. This is the hallmark of SGLT2 inhibitor. The glucose lowering is independent of insulin. The urinary excretion of glucose does not require insulin. So they exert glucose lowering effects even in type 1 diabetes. Insulin requirements are modestly reduced in type 2 diabetes. They appear to be better than sulfonylureas, because sulfonylureas cause beta cell exhaustion and hypoglycemia, which could result in non-adherence and also weight gain. All these could contribute to a poor glycemic control. This is how the SGLT2 inhibition is working. Overall it decreases the glucose and decreases the adiposity. It increases the glucose area and it increases the renal gluconeogenesis. In the liver, it increases glycogenolysis, it increases the gluconeogenesis, and it increases the non-essential fatty acid utilization, and it increases the ketogenesis. So in heart, there is increased NEFA utilization, increased ketone utilization, and there is a improved substrate utilization and switching over. Central regulation, it may increase the appetite. In pancreas, it increases the glucagon output, it increases the NEFA uptake, it decreases insulin, so hence by it decreases beta cell stress. In the adipose tissue, it increases lipolysis, NEFA uptake, and decreases inflammation. So it decreases the adiposity in general. So changes in glucagon, glycogen, and gluconeogenesis are as follows. A rapid early rise in glucagon occurs. It is due to the reduction in paracrine signaling within the islet, and also due to the reduction in central signal triggered by the falling glucose levels. They may also directly act on alpha cells to reduce SGLT1 dependent glucose uptake and promote glucagon release. This results in a reduction of insulin glucagon ratio, and hence it triggers an increase in hepatic glucose production. It is mediated by glycogenolysis and gluconeogenesis. But over time, the demand for increased glucose production is supplanted by other metabolic compensations and glucagon, and hepatic glycogen and hepatic glucose production return to normal. Changes in metabolic substrate utilization and ketogenesis. There is depletion of liver glycogen, and signals that increase the hepatic glucose production, modulates uptake and utilization of glucose in peripheral tissues. These actions protects the brain's glucose dependent mechanism. In this context, it may be regarded that this state is very similar to fasting, hence it is called a pseudo-fasting stage. What happens next? As in the fasting stage, an unnecessary utilization of glucose is limited by increased peripheral oxidation of fat due to increased lipolysis and NEFA uptake from circulation. So any unnecessary utilization is limited, of the glucose is limited, because there is increased peripheral oxidation of fat due to lipolysis and increased NEFA uptake. NEFA is used by the liver to generate ketones, and this acts as an alternative and efficient energy substrate for metabolism. In fact, it is preferred by heart. The contribution of lipolysis and ketogenesis to overall energy metabolism strengthens with ongoing SGLT2 treatment. That is, it is additive and it improves the overall energy metabolism. SGLT2 inhibitors and weight control. They are not licensed for weight loss therapy. But by promoting glucosuria, they achieve a negative energy balance. These are associated with a dose-dependent reduction in body weight. So increasing the doses could theoretically result in decreasing the body weight to a greater extent. The weight reduction is greatest in people having highest HbA1c, and it is attenuated in people with good glucose control. It could be due to the magnitude of glucosuria resulting from SGLT2 inhibition and its impact on overall energy balance. And the weight loss is independent of baseline BMI, sex, race, or background therapy. What is the influence of inhibitors on adiposity? There is an early decline in body weight. It is due to the depletion of hepatic glycogen and associated water loss. But in the long term, it results from loss of fat mass, including reductions in steatosis and visceral and subcutaneous adipose tissue. This is mediated by enhanced fatty release from adipocytes. Why isn't this weight loss greater, or why is it ongoing when the SGLT inhibitors are used for a long time? So it is assumed that energy loss must be initially partly and eventually fully offset by other factors, and a new energy balance and stable weight is reached, as in people who are following a low carbohydrate diet. There could be compensated decrease in basal metabolic rate and increased conservation of energy. SGLT2 inhibition may increase hunger, especially for sugar-rich foods, in a matter similar to exercise, low carbohydrate diets, and new onset diabetes. A modest increase in energy intake will not balance the initial heavy glucosuria, so there will be an early weight loss with SGLT2 inhibitor use. So even if you take more food during the initial periods, due to the heavy glucosuria, there will be a weight loss, but the glucosuria will decline when the glucose control improves. This is because lesser energy losses may be fully offset by increased food intake, and a new energy balance is achieved and the weight plateaus. It's been shown that long-term adherence to low carbohydrate diet is associated with depressed metabolic rate, as energy demanding gluconeogenesis is normalized and other efficient compensations take over. These include changes in substrate utilization, as in the utilization of ketones, for example, mitochondrial network homeostasis, and downregulation of mTOR dependent pathways. So similar changes occur with SGLT2 inhibition as well. SGLT2 inhibitors and their influence on renal function. Let's start with the proximal tubular sodium handling. The glomeruli filter 400 to 600 grams of sodium per day, and the proximal tubule reabsorbs between 60 and 80% of the sodium. SGLT2 reabsorbs 1 sodium for every glucose molecule from the early proximal tubule, whereas in the late proximal tubule, SGLT2 reabsorbs 1 sodium for every glucose molecule from the early proximal tubule, whereas in the late proximal tubule, it is SGLT1 that reabsorbs, and it reabsorbs 2 sodium ions for every glucose. SGLT2 therefore is in the early proximal tubule, and it reabsorbs 1 sodium for every glucose molecule. But the reverse, SGLT1 in the late proximal tubule, and it reabsorbs 2 sodium ions for every glucose. In this way, SGLT1 is more efficient and more potent than SGLT2. The SGLT1 pathway is underused in healthy kidneys, as 90% of the filtered glucose is reabsorbed by SGLT2. Approximately 25 grams of sodium is reabsorbed by SGLT dependent pathways in the proximal tubule each day, and that is equal to 4 to 6% of the total filtered load. In diabetes, there is glucose mediated renal hypertrophy, and it increases expression and activity of SGLT2. It also results in the full recruitment of SGLT1. So SGLT1 is drawn to its full potential, and you can see from 25 gram to 50 gram of sodium is reabsorbed by these SGLT dependent pathways. Hence, increased sodium reabsorption in proximal tubule causes reduced sodium uptake at the macula densa. This activates tubuloglomerular feedback and hence reduces synthesis of vasoconstrictive molecules. Hence, it leads to increased renal plasma flow and increased intraglomerular capillary hydrostatic pressure. This enhanced proximal tubular sodium absorption also reduces the hydrostatic pressure in the Bowman space. As a result, filtration rate in each nephron, that is the SNGFR, increases. When you give SGLT2 inhibitors, it has the opposite effect. Sodium and glucose that is not absorbed proximally via SGLT2 passes distally. Thus, SGLT2 inhibition results in increased delivery of sodium to the macula densa. It triggers a fall in it triggers a fall in the intraglomerular hydrostatic pressure, and it reduces the transglomerular pressure and hence reduces the single nephron GFR. The impact on solute handling by SGLT2 inhibitors. The glucose reabsorption and the sodium reabsorption is energy dependent, and it happens in the proximal tubule. This increases, so as the sodium and glucose reabsorption increases, more energy is required. Thus, it increases the hypoxia and renal medulla, leading to nephron dropout and function decline. Energy dependent sodium and glucose reabsorption increases hypoxia, leading to nephron dropout and function decline. In diabetes, PCT is more sensitive to these imbalances between renal oxygen delivery and oxygen consumption. Hence, AKI is more common and severe in diabetes. SGLT2 inhibitors transfer some of this energy burden of sodium reabsorption from the proximal tubule. Thus, it will protect against AKI. The EMPA-REG has shown a lower incidence of AKI. However, this is controversial, as you can see that most of the SGLT2 inhibitors result in a doubling of creatinine, although it can be reversed by stopping them. Here is the concern when you use the SGLT2 inhibitors in patients who have declining eGFR. Volume depletion following SGLT2 inhibitor. As SGLT2 inhibitor will cause increased glucosuria and a decrease in plasma volume. So this plasma volume depletion will precipitate AKI in some settings. But the sodium and glucose are not reabsorbed in the proximal tubule. Hence, there is a distal shift in reabsorption. This will increase the medullary oxygen demand, and there will be a compensatory erythropoietin production. However, in diabetes, erythropoietin production fails to increase despite renal hypoxia. That could also contribute to the AKI. Other effects are increased uric urea and a decline in plasma urate, also a reduction in phosphate clearance, leading to a 3 to 5% increase in serum phosphorus. It has no direct impact on homeostasis. However, the hypokalemia incidence was reduced by empiric outcome trial, although it was not present in canvas. So to summarize, natriuresis activates tubular-glomerular feedback. It decreases intraglomerular pressure and increases the Bowman capillary hydrostatic pressure, and it reduces the transcapillary pressure gradient, GFR and albuminuria. There is a sustained contraction in plasma volume and enhanced distal delivery of solutes to the medullary nephron segments. The increased energy requirements for solute reabsorption are offset by a compensatory increase in erythropoietin production when you use the SGLT2 inhibitors, and hence it will raise the hemoglobin concentration. Again, glucosuria is associated with improved glycemic control and weight loss, and the loss of glucose and sodium in urine will reduce the proximal tubular ischemia. Again, it will affect the energy utilization and it will increase the erythropoietin production to enhance renal oxygen delivery, which happens in SGLT2 inhibitors. The influence of SGLT2 inhibitors on kidney function is as follows. There is realignment of renal sodium handling, and it is associated with a modest acute reduction in eGFR of 3 to 4 mils per minute, and it is independent of diabetes or CKD. They are also associated with a rapid reduction in urinary albumin excretion independent of the glycemic effects, a reduction in the pressure gradients will acutely reduce the eGFR, and this reduces albuminuria. Also, long-term treatment in SGLT2 inhibitors is also associated with reduced progression of albuminuria and a slower decline in renal function. This is independent of glycosuria, weight or blood pressure. How about the blood pressure control? So aim of target blood pressure in diabetes is supposed to be 140/90, less than 140/90, and lower targets may be appropriate for individuals with high risk of CKD or CV disease. So this is to prevent micro and macrovascular complications, disability and death. SGLT2 inhibitors are associated with sustained BP lowering, both of the systolic and diastolic pressure, in both hypertensive and non-hypertensive individuals. However, the reduction may be greater in hypertensive because of increased sodium and volume sensitivity. A reduction in blood pressure will result in a reduced GFR. Reduction in blood pressure with SGLT2 inhibitors are also seen in renal transplant patients. And the reduction in blood pressure is regardless of the glucose control in both individuals with and without diabetes, because it is due to the reduction in plasma volume. Coming to plasma volume, SGLT2 inhibitors will reduce the plasma volume. Thus, it leads to activation of RAS and suppress natriuretic peptides, resulting in overall promotion of sodium and water reabsorption in the kidney and restoration of the plasma volume. So theoretically, SGLT inhibition can activate the RAS. SGLT2 inhibitors will cause an acute contraction in plasma volume within hours of therapy initiation. And it continues even over years of therapy. the underlying mechanism is not merely natriuresis, and the mechanism is not fully understood, and it is not dependent on the osmotic effects of glucosuria. But plasma volume and sodium are not elevated. In fact, the total body sodium is actually at diminished following SGLT2 inhibition. So there could be a potential effect on the RAS which could be suppressed, unlike the normal homeostatic mechanism. So there could be it will result in a resetting of a new steady state, that is a reduced plasma volume, without activating RAS. Thank you.